Medicaid requirements for the provider's first partition year makes them to be eligible to receive the payment for having adopted, implemented, or upgraded to certified EHR technology. For the first year in which a meaningful use was demonstrated, the minimum reporting period also is 90 days and will be identified by the eligible professional. This allows the providers to receive the first year's payment even if all the requirements were not met until October 1st of that year. States are expected to issue payments on a rolling basis. Thus, once the reporting period is complete and the necessary reports and attestations have been submitted, payment can be issued. In subsequent years, the eligible professionals will need to meet a full 12-month cycle. For the first participation year, the provider must adopt, acquire, or install and be able to show evidence of an installation prior to receiving their incentive. When they implement a system, they begin the utilization of staff training, data entry of patient demographic information, med lists, allergy lists into the EHR. Or they can upgrade, which is expansion or upgrade to a certified system, or add new functionality to meet the new criteria. States can seek CMS's prior approval to require an additional 4 meaningful use objectives for core for the Medicaid providers. California, it seems, is staying fairly close with the federal CMS program and aren't expected to make any major differences or major changes in the type of clinical requirements. They are at CMS for approval, and we should hear something by the first quarter of 2011. Pediatricians with more than 20% but less than 30% Medicaid patient volume can receive up to 2/3 of the maximum amount of incentives, and hospital payments are based on a formula outlined in the statute. The state programs are going to align with Medicare incentive programs where possible. This includes allowing states to initiate their programs as early as January of 2011 and as late as August of 2011. It's going to require the states to verify the eligibility and disperse payments and reconcile that back with CMS. The statute also specifies that the states must have a system capable of coordinating with the national database to verify provider eligibility, identity, and to be able to coordinate and/or make payments. These top 10 EHR lessons learned are everyone's nightmare. We've all heard the horror stories and the incredibly high failure rate of our installations. Education, planning, best practices, and excellent training, along with physician and management support, go a long way to guiding an installation to success. We encourage good vendor relationships. We encourage strong contact with the vendor and use of the vendor for the implementation processes. We strive to educate and train our providers for with best practices and with peer-to-peer networking. We have a provider advisory council and an office management group, which are the EHR champions, and also the management staff are the people that are going to vet all of our training and all of our assessment tools to make sure that we're providing the best type of services that our practices need. As we look at a lot of change that's going to be required across our industry space in the next few years, we have to guide our physician practices towards the ultimate goal of meaningful use. And there are many, many questions and serious business decisions that need to be made. With the help of the HIT community, we will be able to guide these practices towards a common goal with local, regional, and national implications. We've been providing site visits, contract review, workflow analysis. EHR processes we have seen include people that I don't think probably can spell EHR and get the letters right, to those who have steering committees and are going through extended vetting processes in their RFI processes. We provide project management service with the vendor and or the consultant, kind of a wraparound service to make sure that nothing falls through the crack with the training or the documentation or the workflow as we proceed. Physicians do have a choice. They need to look at the changing policies, they need to look at the dollars that are on the table, and based on their individual practice or their individual business decisions, they need to act now, they can wait, or they can say no. We're there to help them. We're funded through 2012 and potentially 2014 with the funding switch. Spurred on by the stimulus funding that begins in 2011, the Medicare penalties that begin in 2015, physicians and hospitals will invest billions of dollars in certified EHR technology. While many providers were planning to implement EHRs in the near future, the government's new regulations dramatically condense their timelines, and they must invest in their technology, IT staff, training, and process redesign. In the long term, EHRs are expected to help control costs and improve clinical quality. Now, if we can only figure out how to transfer data as easily as we can get $100 out of an ATM machine anywhere in the world, we'll be set.